Hello and welcome everyone to the virtual demonstration of a non-contact peripheral Navilas treatment in English language. My name is Panin and I'm, among other duties, a clinical applications specialist at ODOS. Maybe you already saw me during our masterclasses or in this video.
Sometimes, even the most experienced retinal laser surgeons need laser treatment. Now there is a solution.
I hope this clarifies my qualification regarding Navilas application. So let's begin. First of all, if you are a current Navilas user, consider registering in Navilas Academy as it has all the necessary training videos you might require. In this video, we will not cover the lens treatments with Navilas because they are quite similar to what is done on a slit lamp. Before the actual demonstration, I'd like to present you this clinical case, which nicely demonstrates the capabilities of Navilas non-contact optics. As you see, OCT imaging was performed before and after the treatment to ensure the treatment transparency. Patients prefer Navilas treatments in general due to less pain and discomfort, but non-contact treatments improve this further. Here you can see the treatment plan around the retinal tuft and the result right after the treatment. You can find the treatment settings at the bottom of the screen. As you see, the pulse duration used for the treatment was in the lower part of the treatment setting spectrum. 30 milliseconds is often considered as milder settings. You can decide yourself after you see the OCT control after 2 weeks. This time I will not explain the treatment planning step. Instead, I will use this time to talk about the practical use. Apart from being a kinder way to treat your patients, this approach is very much appreciated in cases when doctor doesn't want to touch the eye. For example, when laser is needed right after the surgery, those cases are rare, but they happen every once in a while. Similarly, the non-contact approach can be very useful when treating children or other types of patients with poor compliance. Like in the first winter school webinar with Professor Harold, where she shared her experience with an extremely uncompliant patient. Coming back to the treatment we see on screen, it's not speeded up, it's real recording. The plan is halfway finished already. The patient sits calmly, which makes the treatment very quick. I wouldn't say that every treatment turns out ideal like this one that we see on the video, but in my experience we had many beautiful cases like this on the first day, just following the considerations I'm about to share. By the way, have a look at the second week's results. I think they speak for themselves. So, what do we start with? It is recommended to have everything you might need on your table before you start treating with contactless wide field objective. First of all, make sure you have disinfecting tissues. Disinfection should be done with 99% isopropyl alcohol or Crystal Trio special wipes. You would also want to have some soft cleaning tissues to remove excessive liquid from the objective if you accidentally touch the eyelashes. Artificial tear and BSS can be helpful if patient has dry eye. Dryness of the cornea influences the transparency, thus it's necessary to have cornea moisturized all the time. Anesthetic drops prevent patient from blinking. Q-tips are needed to hold the upper eyelid. Usually it is very recommended to do proactively when you are treating the lower hemisphere. With upper hemisphere, there are only few times when you would need Q-tips to hold the upper eyelid. Start by instilling anesthetic to both eyes of the patient. The lens works in close proximity to eyelashes, which can lead to some tear film occurring on the surface of the objective, which will decrease our visualization quality. We don't want that. Thus, we instill anesthetic to both eyes to prevent patient from blinking. Another important thing is to mind the working distance. If you are working too close to the cornea, as I mentioned again, you can get the objective dirty and the visual properties will be decreased. So try sticking to the ideal working distance, which is demonstrated in the middle of the slide. In this example, you see that retina image is round and it's touching the vertical borders of the screen. And on the right, you can see the example where the operator moved the camera too close to the eye. This is something you want to avoid. Another useful advice would be to proactively turn on the color illumination while you plan your treatment and ask patient to look at it, just so that the patient can adapt to the bright flashes of the laser which will happen during the treatment. This is what you see now is an example of a simulated treatment performed in our office during training of doctors. In this case, the patient is dilated, so we can use color illumination. It is also possible to treat with infrared illumination, as will be shown later. But for real clinical treatments, it is highly recommended to use color illumination because it reduces patients' reaction to the bright light of the laser itself, and because it allows doctor to visualize the treatment effects much better and deliver the treatment in the best quality possible. So here is the example of far peripheral laser treatment simulation on my colleague's eye with infrared illumination. It can still be done as mentioned before. It's just that we do it this way in this case only because she does not have any mydriasis. This case nicely demonstrates the capabilities of non-contact wide field optics Navilas has. You can see the pupil is not too big. It's also not too small, but it's not a pupil which you would call dilated. First of all, what I need to do is to position the focusing lines. We need to project them on the retina to focus the objective. Usually, once you set it in focus by rotating the rubber tip of the objective, you don't need to change the refractive of the objective anymore. One quick hint is to halfway unscrew the rubber tip before you even start to focus it. This way, your objective will be by default focused to a metropic refraction, and it will be easier to proceed from then. Another pro tip is to focus the objective while the objective is far from the eye, because the working distance doesn't actually influence the refraction of the objective, so you can adjust the focusing without being in close proximity to the eyelashes. So patient can blink, and you do not need to restrict him from that. Once you have your lines vertically adjusted, you can slowly start moving the device base towards the patient eye, avoiding the eyelashes and not moving closer than this. Right after making a picture, pull back the base and make sure it doesn't stay close to patient's eyelashes. Planning the treatment is more or less the same as any peripheral treatments with Navilas. Additional recommendation is to position the spots a little bit further from the border of the image, just because it will make it easier during the treatment. To treat far periphery, it is recommended to use the green focusing diode on top of the chin rest. We can move it to the side and ask patient look this direction, then look at this green diode. And also we can slightly adjust the head position. For example, if we want to reach the upper segment, we want to put something between the headrest and the forehead. Now I ask the patient to look slightly upwards and right, and we get a beautiful image of superior temporal retina, mostly temporal. You can see here almost up to ora serrata. And I remind you that the patient does not have any mydriasis. The algorithm for camera handling is practically the same. You centrate your camera on the retina reflex. Make sure you do not confuse the retina reflex with the central reflex of the objective, which you can see now at the top and at the bottom screen. This central reflex cannot be removed, so do not mix them up. To go to far periphery in superior quadrant, we want again to put something between the headrest and the forehead in order to position the head a little bit slightly upwards and make it easier to the patient to look upwards. Oppositely, for treating at far periphery 6 o'clock, we want to ask patient to look at his boots, like looking through the table, and ask patient to slightly pull back his or her chin. Here I made one more picture, not that peripheral, but more in the superior area. You saw how quick it was. I put 2 caution zones to protect the whole posterior pole, and I'm going to plan a retinopexy treatment, which will be simulated in the area near vertex veins, which is considered to be already a far peripheral retina. Again, I remind that patient does not have any pupil dilation, so I activate the laser system in simulation mode, slowly pushing the base towards the patient until I see retina reflex. I centrate on this retina reflex. I centrate the camera. Do not confuse the retina reflex and the camera reflex, and also the focusing lines. And you can see the plan is being projected on the retina, and the spots are being delivered. After making several shots, maybe 2-3 shots, you want to stop, make a picture, and determine the coagulation threshold you currently have. If the spot is not visible, it is recommended to ask patient to blink a little bit to moisturize the cornea. This will improve the visualization. I will have a separate slide regarding the cornea dryness. Here it is. If you see 2 so-called green lines, like on the left upper image, it indicates corneal dryness. But if the whole image is blurry and refraction adjustment doesn't help, it means that the cornea is way too dry and some artificial tear should be administered. If you can see the same 2 lines with some roundish drop-like distortions, then it means that there is some tear film on the objective lens and it needs to be cleaned. Vignetting of the image is usually caused by poor handling. Pull back the base, position the retina reflex in the center of the screen, and slowly move the camera forward. Repeat until the working distance is reached. Eyelashes can also be seen on the camera image, and the upper eyelash is visible at the bottom of the screen. Make sure you hold the upper eyelid if you treat in the lower hemisphere. Take-home message. Learn to keep the working distance. Don't neglect holding the upper eyelid. Do everything to keep the objective clean. Let the patient blink every 30 seconds to make sure the cornea is not dry. Here are some red flags when you shouldn't continue with a non-contact objective, especially during the first treatments. In case of bad fixation, strong opacities like cataract or hemorrhages, it is better to continue with a contact lens. It is not impossible to perform such a treatment on a non-contact objective, it's just less convenient and takes more time. If one of your first few patients has a retinal condition in far periphery at 12 or 6 o'clock sharp, then it is better to continue again with a contact lens, because this area can be challenging to reach with low level of experience. For big treatments, it's better to go with a lens to save time. High and irregular astigmatism as well as severe corneal dryness can also make contactless treatments way too difficult and at some point even impossible to perform. Use contactless instead. Thank you for your attention.